Hi, Carolyn. I'm happy to see you. Are you going to come into the game?
Yes.
Okay.
Perfect, thank you.
Awesome. All right, we'll start. The most common non-obstetric surgical emergency during pregnancy. Yep, appendicitis is the most common non-obstetric surgical emergency. Procedure that involves placement of a suture around the cervix beneath the mucosa to constrict the internal os.
Why it's not letting me choose anything?
Oh, that's weird. Earlier when we played the game, there was a few questions that it wasn't. I think the game was being glitchy.
Yeah, it might be because I got it on my phone, but it's still not. I don't
Not
know.
letting you pick.
Yeah.
So you're not going to be able to win on points, but that's okay. If it doesn't let you choose, you can also call out your answer if you want. The answer for this is the cerclage. Okay, so when do you guys think we would use a cerclage?
Incompetent cervix.
Incompetent cervix. And so the cervix is starting to open and it's getting thinner, and we're way early, like second trimester to beginning of third trimester. They might do this and stitch it so that it doesn't open. Disorder that results when an egg without an active nucleus has been fertilized. This is also gestational trophoblastic disease. This is when you get that big proliferation of cells, but it's not really a baby. And she can have weird symptoms with bleeding, hypertension, nausea, and vomiting. And her body thinks it's pregnant. So her uterus is enlarging because of all these cells dividing. And her HCG levels are high, but it's not actually a baby. And this can lead to a lot of bleeding. Or Markeia doesn't get to answer. Implantation of the placenta in the lower uterine segment, totally covering the internal cervical os. Good, a complete placenta previa. So if your patient has a placenta previa that you know of, what signs and symptoms might you see?
Bleeding.
Yeah, bleeding. Is it painful or painless?
Painless.
Painless bleeding. If you don't know that she has a placenta previa, she has painless bleeding, how could we find out?
Oh, sonogram, ultrasound.
Good, ultrasound. If I don't know, should I check her cervix?
No.
No.
Well, you
No.
wouldn't know, so you would still check it, but then
Well, but if she's having bleeding that's
oh
painless,
no, yeah, no, we wouldn't check it.
like if I have a girl that comes in and she says, I'm having bleeding, and I say, are you feeling any contractions? Are you having any pain? And she says, no. If she's having contractions and pain, maybe I would check it and hope for the best. Okay. If your patient has a complete placenta previa, what's the route of delivery for her?
C-section.
Yeah. A renal infection that is a common serious medical complication of pregnancy. All right. If you didn't know the answer to this question, how could you break it down and try to decide what it might be?
Nephritis is kidneys.
The infection.
Okay, so the fact that it says infection is going to let you rule out two of these answers, right?
Right.
Okay, so we can narrow it down, and then we can look at those two and see if there's any clues. And so you might be able to identify that neph is renal. If not, you've at least narrowed it down to 50-50, because we're talking about an infection. And actually, I'm misreading this. This doesn't even say itis, and I thought it did. This is cholelithiasis, which is gallstones. So we actually could take away urea, and iasis because we're looking for an infection, and we could pretty much pick out the itis because we're looking for an infection. So I was even misreading blue, so I could even eliminate that one also. So I'm looking for an infection. Presence of a BP of 160/110 or greater on 2 or more occasions 4 hours apart may include systems of organ involvement. Okay, you're correct. Preeclampsia, severe preeclampsia. So when we think about how we determine if it's severe, part of it is a blood pressure greater than 160/110. What other symptoms, when it says symptoms of organ involvement, what other symptoms might we see?
Less urine.
Less urine. Lower than how much?
30 an hour.
Lower, less than 30 mLs per hour. What else might we see?
And she's pregnant, then seizures.
Okay, so if she has the seizure, now we are having eclampsia. We've crossed the threshold. So before the seizure happens, what other things might we see that could give us a clue that she's at a high risk of having a seizure?
Dizziness, blurred vision.
Okay.
What's that?
Yeah, blurry vision, fuzzy vision, spots before her eyes, lots of visual changes can be seen here. What else? What about, do you think that she might have headache?
Yeah.
Okay, headache is one sign. What about if it's involving her kidneys, then what might we see in her urine?
Protein.
Protein. Okay, so hypertension, proteinuria, headache. And it's a headache. It's a unrelenting headache. Like she's taking Tylenol, it's not touching it. Okay, we said visual changes, thrombocytopenia. What does that mean? What's low with thrombocytopenia?
Platelet.
The platelets are low. Okay. Yeah. Okay. A variant of severe preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelets. Okay, this is HELP syndrome. And so with HELP syndrome, we have preeclampsia and we have these other variations. So we still can have thrombocytopenia, but typically those platelets are lower. They're like under 100,000. Right upper quadrant pain because of the liver involvement. So she can have pain on her right side. Her liver enzymes, so her AST and ALT are high. Her fibrinogen is low. In preeclampsia, usually it's not, but with HELP syndrome, it is. And then the symptoms we're already talking about, like headache, edema, stuff like that. This is concerning. Any idea how we would treat HELP syndrome?
I'm sorry, what was the question?
Any idea how we would treat HELP syndrome?
Is it fluids? Give them. No.
No, because we're actually going to be restricting the fluid because she's just third spacing all of it. So HELP syndrome is a variant of preeclampsia. So how do I treat preeclampsia?
Magnesium.
Yep, and that's how we treat HELP syndrome as well.
Okay.
Magnesium sulfate. Yep, good. At 32 weeks gestation, we have hypertension since 28 weeks, hyperactive DTRs with clonus, proteinuria 4+, and she has a convulsion. So if she's actually having a convulsion, so let's think about our symptoms. And actually this hyperactive DTRs, it was the symptom that I was missing. I was thinking when we were talking about symptoms for preeclampsia a minute ago, I was like, what am I missing? The DTRs. So what we're thinking about with this patient is hypertensive, hyperactive DTRs with clonus, and proteinuria. So what does she have based on those symptoms? She has preeclampsia. Yeah, she has preeclampsia. Yep. Now she has a convulsion. So now we've crossed that line where she's preeclamptic, now she's eclamptic because she's having the seizure. The whole thing with preeclampsia is, and we give a magnesium sulfate. The magnesium sulfate is to try to prevent the seizure. And now she's having a seizure. So that's eclampsia. What do you think the priority is for eclampsia if your patient's having a seizure?
Airway.
Absolutely. Yep, safety and airway. Let's keep her from, convulsing off the bed or smacking her head on a side rail, and let's put her on her side and protect her airway until the seizure's over. And then if she's not on magnesium sulfate, she'll get it to try to keep her from seizing again. The drug of choice in the prevention and treatment of seizure activity or eclampsia caused by severe preeclampsia. magnesium sulfate. So we're giving her magnesium sulfate. We're trying to do what? What's the point?
Lower the blood pressure.
Well, so the magnesium sulfate sometimes can have that effect as a side effect, but it's not really why we're giving it to her.
Prevent the seizures.
Prevent the seizure. That's why we're giving it to her, is to try to prevent the seizure. And so it's going to take her body that is having like hyper reflexivity and all these issues that can cause a seizure, and it's going to simmer that down. Okay. To try to prevent the seizure. An anti-metabolite and folic acid antagonist used to destroy rapidly dividing cells. This is what we use to manage an ectopic pregnancy. Methotrexate, good. What's a normal blood glucose level? Not the number, what do we call it? Okay. Euglycemia is the word for normal blood glucose level. So if I didn't know the answer to this, this is talking about blood glucose, and glucose urea is talking about urine. So we could probably eliminate that one. Hypoglycemia is going to be hypo is low. So we could probably eliminate that one because it's not normal. And then if I didn't know what polyphagia was, then I've gotten myself down to 2. This one says glycemia in it, so it's talking about glucose. So I don't know what this one's talking about. So that might be a way to break it down if you weren't sure. Excessive fetal growth, birth weight greater than 4,000 to 4,500 grams or greater than the 90th percentile. All right, this is macrosomia. Baby, excessive fetal growth, the baby's big, greater than 4,000 grams. If the baby's, what kind of conditions might lead to macrosomia, do you think?
Diabetes.
Diabetes is a big one. What's something we can do for moms, have moms doing during their pregnancy to help decrease the risk of growing a macrosomic baby?
Nutrition.
Okay. Yep. Yep. That's good. What else? We want her to keep her blood glucose levels very steady. So we're going to encourage her to do finger stick blood sugars every day. And so that she maintains that steady glucose level. She doesn't have those big peaks. Because if she's having periods of hyperglycemia, that's what causes babies to grow to be macrosomic. If your baby's macrosomic, what risks go with that?
You say if they are.
Mm-hmm.
Would they be like an increased like risk for like they get like a C-section?
Yep. Yep. That increases the risk of mom needing a C-section because the baby might not fit through the pelvis. What else?
After the baby, we had to check the glucose levels because they're
Good.
hard.
Good. Yep.
Yeah.
So babies at risk for hypoglycemia after birth. The other thing I would think of for baby is risk for birth injuries. So if she has a C-section, the baby wouldn't be at risk for birth injuries, but if she delivered vaginally, then we could have where the baby gets stuck. What's that called?
Dystocia.
Shoulder dystocia. Good job. This is acute idiopathic facial paralysis that can occur during pregnancy. Bell's palsy. Bell palsy is it causes facial paralysis and it's on one side of the face. And it often happens in pregnancy and it often happens accompanied with preeclampsia for some reason. But if your patient is having facial drooping on one side, what would I be worried about? Yeah, maybe she's having a stroke. So we have to rule it out. But so it could be Bell palsy. And that's a neurological thing. It takes a long time to recover from. A detachment of part or all of the placenta from its implantation site. Yep, placental abruption or abruptio placentae. Both of these words are used interchangeably. They both mean the same thing. Okay. If it's detaching from its implantation site, then that's what we think is happening. What kinds of signs and symptoms might I see for that?
Dark red blood.
Okay. Yep. What else?
Pain.
Yes, this one is painful. Okay. Any other signs and symptoms we might see?
Um, they're the only two that I really remember.
Yeah, that's good. Also, the abdomen might be rigid, board-like, tight. And on our fetal heart tracing, what might we see, do you think?
Low. Fetal heart rate.
We might see late decelerations because this is affecting blood flow to the placenta. Good job. Pathologic form of clotting that's diffuse and consumes large amount of clotting factors causing widespread bleeding. This is DIC. Okay, what signs might I see that would clue me into DIC?
Peaky eye, bruising.
Maybe. Yep. So if we're having a clotting issue, just think about everything can bleed, right? So maybe we're bleeding from the IV site. Maybe we're bleeding from previous punctures. Like if she had blood drawn, maybe we have blood in the urine. Everything can bleed because nothing is clotting like it's supposed to. And so also petechiae, because that blood pressure cuff is squeezing and those little capillaries are breaking. Also, we'll see signs with this of hypovolemia because everything's bleeding. So what else might we see? Besides we're seeing the bleeding, what else might we see for her?
Vomiting.
Say that again.
Vomiting. Throwing up.
I don't know. I mean, yeah, maybe, right? Because what would her blood pressure be doing?
Dropping, so she'll go in the shop.
There you go. There you go. That's what I want you to think of for this patient. I want you to think about hypovolemic shock. So truly, if her blood pressure drops, she might vomit. Because you know how you feel sick when your blood pressure gets low, and you can also feel dizzy and diaphoretic. And what else is happening with her vital signs? What's her heart rate gonna do?
Oh,
Mm-hmm. Okay, so for your DIC patient, you're seeing all this bleeding happening and you're also seeing signs of hypovolemic shock. Okay, good job. Excessive amount of amniotic fluid. Okay, this is polyhydramnios. We have a lot of amniotic fluid. So what is oligohydramnios?
Probably less.
It's going to be low amniotic fluid.
It's that time.
So for polyhydramnios, we see this oftentimes with things like diabetes. There's a lot of fluid. If I have a lot of fluid, I have over distension maybe of the uterus. So I can see things like increased risk for bleeding after delivery, things like that. With oligohydramnios, my fluid level's low. If the fluid level's low, what do you think we might see?
With the baby or with the mother?
This one is largely going to affect the baby.
Their skin is gonna be stuck to them. Like it's gonna be like the hair. I know it's something with their skin. It's gonna be like kind of dryish. Their hair is.
They definitely can have dry skin if they go past their due date. If our fluid level is low in utero, there's still some fluid. So that we're probably not going to have the dry skin for that. But I would think about, what does amniotic fluid do? If you go all the way back to week 2, what's the purpose?
The cushion.
Yeah, cushion and protect, right? I mean, there's other things, but if my fluid level's low, maybe I don't have as much cushion for the umbilical cord. So maybe we're seeing variable decelerations because we have cord compression. That's going to be the biggest thing I see with oligohydramnios, is that it's just not enough fluid to cushion the cord. Polyhydramnios, in addition to overdistending the uterus, the other thing I would really worry about this is when the water breaks. There's a lot of fluid that's going to rush out. What could it take with it?
The cord.
And then what emergency does that create?
It's not. Thank you. Prolapse.
Yep.
So you have to go do a C-section.
Have to do a C-section. Before we go to the C-section, if we have a cord prolapse, what do we need to do?
Cover the cord when it's wet.
We could cover the cord. What is even a bigger priority? What do you think? If the cord is in front of the presenting part, do you think the presenting part, probably the head, is putting pressure on the cord?
Yes.
Is that going to decrease oxygenation to the baby?
Oh, is that where we shift the mother, like make her knees and hands and knees, bring the knees above to the chest?
Okay, we can do knee chest where the knees are on the bed and the chest is on the bed and her butt's way in the air, and that's going to let gravity pull that baby back off the cord. So that's one of the things we could do. We could also do Trendelenburg, where we lower the head of the bed to help gravity rock the baby back. We can hold the baby with our fingers, like in the vagina, hold the baby off the cord. The goal is going to be to keep the baby from putting pressure on the cord until we can get the baby out with a C-section. So these are all things that we think about with amniotic fluid. A hemoglobin level less than 11 in the first and third trimester is mainly the result of this deficiency. Okay, if our hemoglobin level is less than 11, that's anemia. And most commonly it's caused by an iron deficiency. It's iron deficiency anemia. And I know that like when the new NCLEX comes out, they're going to have your lab values posted, but I don't think they're posted yet. So that's one to keep in mind. Inability of the heart to maintain sufficient cardiac output. Cardiac decompensation. So if she has, remember that she has more volume in pregnancy. And if the heart can't keep up with that volume, we're going to start seeing signs of cardiac decompensation. What kind of things might we see?
Fatigue.
What's that?
Fatigue.
Yep. What else? This is going to be your patient that kind of has signs like she has a lot of extra fluid volume, like an overload of fluid volume.
Swelling.
So, swelling. What else?
Oh. Difficult to breathe.
Yeah. All right. So we'll see like tachycardia, the heart's working harder. Moist lung sounds because the fluid can go to the lungs, increasing edema, jugular vein distension, things like that. I don't think the score is very accurate since Marquia couldn't always answer her questions. That said, though, we still got to give props to Nisha. Nice job.
Yes.
Thank you.
So, do you guys want to play the postpartum game?
We can.